All right, well, welcome and thank you, Jim, for joining us. And thanks to our audience for joining us today. I'm Katie Schubert, and I'm president and CEO of the Society for Women's Health Research, which is a national nonprofit dedicated to advancing women's health through science, policy, and education, while promoting research on sex differences to optimize women's health. And our vision is really to make women's health mainstream so that anytime we are thinking about women's health from a national perspective, from a research perspective, that it's not a special population and we're just building it right back into that biomedical research spectrum. So we're delighted to have you here, Jim, and I hope that you could just briefly introduce yourself before we get into some questions.
Thank you, Katie. I'm delighted to be with you today. I'm Jim Taylor, James Taylor. I am president and CEO of an organization called Voices of Alzheimer's, which promotes the equitable and fast approval and coverage of new dementia treatments and devices in our efforts to promote cognitive health across the country.
That's wonderful and very needed as we're thinking about this topic currently, but also historically speaking. And you launched Voices of Alzheimer's with your wife, Jerry, in 2013, whose memory lives on in your work today. But I'm hoping you could maybe share a little more about your story and Jerry's story and what motivated you both to co-found this organization.
So my wife, Jerry, who was diagnosed in 2012 with mild cognitive impairment, which most often leads to Alzheimer's disease. She was a nurse by training and a hospital administrator by profession. She participated in research for several years. So she began countering cognitive impairment back in her mid-60s and noticed the signs, and she knew there was Alzheimer's or dementia in her family. So she was diagnosed after a couple of years of noticing symptoms. She was quite relieved, I would say, with the diagnosis. She essentially self-diagnosed. For me, it was really devastating. I was just shocked. Had a wonderful partner. I couldn't imagine losing her over time. So it was a tough adjustment. But we found in our advocacy that began within a year or two that there was so much opportunity to help people. I think we tend to think that, well, we'll let the Alzheimer's Association do it, or let the government do it, or pharmaceuticals do it. But there's so much that individual people can do. And it is such a rewarding endeavor that we really found that it was a great opportunity for us to get the richness of the Alzheimer's journey. Additionally, we found out as Jerry applied to be in a clinical trial that she had two genes, one from each parent, which increased significantly the likelihood that she would develop Alzheimer's. It made almost a certainty that she would develop the disease. And she knows that she has passed one of these genes to her son and possibly to her granddaughter. So for us, it's very personal. So finding a cure someday is what we strive for. But in the meantime, we're trying to make as many small and large steps along the way as we can.
Well, thank you for sharing that. I think one of the things that I was surprised to learn, even though I've been in the women's health space for a long time, I was surprised to hear that, two-thirds of Alzheimer's patients are women. And that wasn't something that I think was necessarily on our radar, although we know there's differences in the brain and the brain development and brain function. But I think that's something that we think about at the society, and we're seeing more people talking about it. So we appreciate all that you're doing. I wonder, as you think about this experience, both as a caregiver, but also through your work at Voices of Alzheimer's, what challenges are families facing when they're accessing care and their support for their loved ones?
I think the challenge of facing Alzheimer's is both internal and external. Um, it's a tremendous adjustment to the fact, once diagnosed, that you or someone you love, if you're the care partner, will be living with a terminal condition. And that's a life-altering realization. And I think it's very important that we individually take the time to adjust to that before we begin to interact with society or tell our children or whomever about it. For me, it was very, very difficult. My wife being a health professional, it was easier for her. She'd lived with the symptoms, she'd lived with the family, but I hated the thought of losing my partner and and becoming a care partner. But so I think that adjustment is important. And then how we interact, whether or not we're going to choose to feel sorry for ourselves and sit on the couch and decline, or whether we're going to make a choice, and I believe it's a choice to live joyfully and live fully after the diagnosis. Externally, we need to understand what life choices we're going to make. Um, we need to educate ourselves about the disease. We need to build our support systems and interact. I believe the Alzheimer's Association is the best organization with chapters around the country with wonderful programs for people with the disease and care partners. That's very important. But another critical decision now, Katie, is one, will I participate in clinical trials to find a cure? Unfortunately, less than 1% of people living with Alzheimer's are participating in clinical trials, and that really slows the opportunity to find a cure. But now, miraculously, finally, after decades and billions of dollars of research, we have FDA-approved medication treatments that will slow the advance of the disease. It's not a cure. It does not reverse the disease, the cognitive loss, but it will probably add a year or two if it's administered in the early stage of the disease. And it adds those years that time in the early stage when we are most vital and most able to live fully, maybe a little more forgetful. I'm already forgetful, but Jerry really had a wonderfully long early stage, and she was on some in the clinical trial for these now approved medications.
I mean, that's a really great point, I think, as we think about how do we make sure that we're paying better attention to sort of what we're seeing and what we're experiencing. How can we make it okay to seek that earlier or more timely diagnosis or even screening? I think that's really scary for many people because they don't necessarily think of it as an opportunity or to feel relief, like you had shared, right? They feel very worried about what that means for them and their families, and they think of it as a very important issue that maybe they do or don't want to know. And so that's definitely a big conversation that's happening now. And I know that's something that you all have been working on in terms of legislation, to think about how you can create an exemption for younger onset Alzheimer's disease and qualifying for Medicare disability. Can you talk to us a little bit about that?
5%, 5 to 10% of people with Alzheimer's are what are called young onset, so earlier than 65, at which point they haven't already registered for Medicare. So they're too young for Medicare benefits. But there's a process by which they can apply for Medicare disability and receive Medicare coverage. That process requires actually 24 and 5 months, so a 29-month waiting period before you can start receiving Medicare benefits. That process has been waived for people living with ALS through legislation on the Hill. Now we have FDA-approved medication that's extremely important to be administered in the early stage of the disease. If you have to wait 30 months just to qualify for Medicare and you're not covered by other insurance, you're going to run a high risk of missing the period, the window in which you will be helped by this medication. So we feel there's an excellent reason. We also believe to possibly delay the decline saves money for the healthcare system because most of the costs of dementia is incurred in the late stage. So that we believe that that's a benefit that the healthcare system should want to ensure that everyone possible is diagnosed early and treated with Medicare, with these drugs through Medicare. So we're beginning to write the legislation that we want to introduce after the election being, of course, the pivotal point in the fall for us. But we have many, it's very much a nonpartisan issue, Alzheimer's support on the Hill, and we have wonderful champions on both sides of the aisle. So we will be reaching out to them after the election, bringing forward legislation that they hope they will sponsor and find co-sponsors for. And then trying to do the public information and lobbying efforts that we need to do with our members, and very much appreciate this opportunity with you to do so. But we look forward to a good outcome there.
Yeah, well, I mean, that's really exciting too. And it is an interesting timing, right? As we think about the end of this current congressional session. We are, as of today, when we are recording this, we're just a couple of weeks away from the presidential and federal elections in November of 2024. But Congress has to start everything over when they come back in January. And so they really hold the key to a lot of this. So we will really look forward to seeing when you're ready, for us to activate our grassroots networks and make sure that we can, be of assistance in getting more support for this, because I think it's a really important topic and should be really should be taken up in a bipartisan way, right? So I think that's really exciting. I know there's lots of other pieces of policy or legislation that are currently shaping Alzheimer's care and research. And wanted to give you an opportunity to talk about maybe some of those other areas that you're seeing and hearing about and what their impacts might be on families and patients.
I would like to have that opportunity, so thank you, Katie. You know, I didn't grow up in the industry. I'm not clinical at all. I just married nurses, two of them actually, but one at a time. And so I want people always to understand that I'm speaking like they, as lay people, but have learned a lot in the last 10 years. And, one of the things I've learned is how radically the AIDS and HIV activists changed what's defined as patient advocacy. We owe so much to them. They were radical, and they had to be. They had to get attention. But I believe they really were forerunners in shaping the FDA opinion, Federal Drug Administration's opinion about the importance of patient input, caregiver input, so that now FDA listens to the AIDS and HIV activists. That message did not get to CMS, to Medicare, I believe. Medicare, in my opinion, has had a historical bias, a prejudice against people living with dementia. We have had a number of instances where we feel that we have been treated much differently than people with cancer or other terminal illnesses. For 15 years, we've had a PET scan that was a diagnostic tool that could be used. No PET scan for cancer is not reimbursed by Medicare, but this PET scan for the definitive test for Alzheimer's was not reimbursed until last August. So many people are currently misdiagnosed with Alzheimer's because they did not have the diagnostic tools. So we believe that we have to continue to work with CMS to help them hear the patient voices, which we really try to do. Is people respond to their peers who they understand are living with a challenge, and I think they listen to the voice of the patients. However, one of the challenges we have in these new approved medications is that we worked very hard to get them covered by Medicare, but they were covered in a way that was unique to any other drug or class of drugs, in that they were classified as needing continuing CED, continuing education development, continuing CED. Help me there. What's
Coverage with evidence development.
Coverage with evidence development. Thank you.
We have a
And
lot of acronyms, as you know.
I know. So the restriction they placed on these two medications is that we as Alzheimer's patients are entered into a register, and before we can be covered by Medicare, we have to be in this registry. But no other class of drugs is required to participate in a registry. It was never the reason AIDS activists did not talk to CMS is because it never occurred to them that the FDA, who's responsible for determining the safety and effectiveness of the drug, would not automatically be covered by Medicare. Historically, that's what has happened. And however, Medicare has taken a different approach now and we believe, assuming responsibility that belongs with FDA, and are restricting these drugs such that they need a registry. No other drugs have that restriction now, but we fear that it will become more common. and it could be used to allocate medications in the future by restricting access to the drug. So that's a real risk to all medications in all disease areas. So we're trying to continue the pressure on CMS, the Center for Medicare and Medicaid Services, to eradicate, to take away and discontinue CED for Alzheimer's drugs. CED is appropriate in device areas, but not in medications, in our opinion.
Yeah, I think this is a really interesting and tricky policy, right? Because as you noted, it actually is related to an entire class of drugs. So it's not just for specific drugs. So there are huge implications for that for the future. I think one thing that we were looking at with respect to this particular policy is that it's not equitable, because even though the drugs are approved, you don't have access to them. You have to be near an academic medical center, probably, right, to be able to be in a clinical trial or in some sort of evidence development process. And not everybody lives near, a center of academic research. There's also issues surrounding inclusion in clinical trials if you have multi-morbidities, other chronic conditions, which, let's face it, most people of who are Medicare
Right?
beneficiaries have other things going on. And so I think it really does get to this place of how can we make sure that patients and their care partners, right, are able to access the full breadth of what's available, especially new and exciting, innovative therapies that we've never had access to before. So I think it's a really important thing, and it is a very policy wonky, topic. So
It
I think it
is.
does, it can confuse people, even me who has been doing health policy for a million years. So I think I love the way that you described it. I think it's really important to get the word out on that. I also wanted to ask about whether you all had worked on potential recommendations related to screening, particularly for folks who might be over the age of 65 and asymptomatic. Is that something that you all are thinking about and looking at?
Because we now have medication that can really make a difference in the early stage. My wife was on medication, on one of these drugs for a number of years. It's not just that it lengthened the drug was subsequently approved by the FDA, and we feel very confident that it lengthened her life in the early stage of the disease, which was wonderful because that's when we were traveling and advocating. But not only the physical benefit, but the psychological benefit of being in a clinical trial or being on a medication that you believe is effective is tremendous, not just for you, but your entire family, your community. And so getting as many folks as possible who are comfortable with the medication is really very, very important. It's very personal for me. There are a number of big challenges. One is the public information that people in my age group who are on Medicare are aware of these treatments that are life-altering. And we all go for an annual physical, an annual wellness visit with Medicare. And Medicare is reimbursed to the physician, and it covers an annual cognitive screening. However, most general practitioners, family physicians, are not trained, not supported, don't have the tools to do a cognitive screening, and therefore it's generally not included in the annual wellness visit. We want to inform people that they're entitled to it. We want them to push back on their physician when he says, well, let's watch it and we'll do it next year. That's a continual next year, then the next year. So we want people to know that they're entitled to cognitive screening. The technology of cognitive screening has come a long way, and we're really about to have a whole new generation of AI-aided digital assessments, which will make it much easier in the next year or two. But we have to advocate for ourselves, Katie. We have to say, well, if you don't do it, who in your practice does give annual cognitive? And well, if your practice doesn't do it, is there someone else you could suggest? Because I think it's important to have it now. So that's important. But it's also important that we address the complement to that, which is the physician education and support. So Voices of Alzheimer's, our organization, we call VOA, Voices of Alzheimer's, is working with an excellent physician education program that was developed by an internist out in Washington State and has gotten extremely positive evaluations and pilots. We connected Dr. Barak Gaster, who developed this training toolkit, with the AAFP, American Academy of Family Practitioners. So family physicians, it's over 130,000 family physicians in the US. They headquartered in Chicago. The CEO of AAFP has made brain health a priority. I mean, it's just incredibly fortuitous and fortunate for us. So AAFP reviewed this toolkit and endorsed it. They believe that it's an accelerated 3 30-minute training videos, a toolkit, support, champion in the office. And it's really what they believe is will expedite the broader education of their physician members. So we're thrilled to be a sponsor of that. It'll be over 2 years. So we hope that the first year is going to be an expanded pilot, but the second year then we'll actually be working with all of these physicians. Generally, most physicians now are in a practice, so there'll be a champion in each office and a lot of support from AAFP and what they've learned through the years in moving into new education areas.
That's amazing. I think that's really going to lead into these broader conversations between patient and family and the clinician, because that's really at the end of the day, right? What's going to get you there.
Absolutely.
Yeah, I mean, that's amazing. That's fantastic. What gives you hope for the future of Alzheimer's research and policy? What are we looking to get to?
You know, when my wife was diagnosed 12 years ago, there wasn't a lot of hope in the community. There wasn't anticipated breakthroughs either in the technology of screening and diagnosis or the medications that were being developed. In the last 3 or 4 years, we've seen incredible breakthroughs. It's hard to keep up. So many things are happening at the same time. Katie, I'm having a hard time keeping up with where we are, which is one of the reasons we're trying to publish a paper that kind of says, okay, here's where we are today, the fall of 2024, and get it published in the Journal of Internal Medicine so that general physicians can know where we are today. What gives me hope is that there is a growing consciousness that Alzheimer's is becoming a treatable disease. It's still a fatal condition, but we can add a year or two to the early stage if it's treated. Also, the conversation is happening and people are realizing they need to advocate for themselves. You know, we always had I always in the past had well, let the Alzheimer's Association, let pharma do it. But no, I've got to take care of myself. So I've got to push back on my physician and say, I know you don't want to, but I really need to have a cognitive assessment, a cognitive evaluation, either as to see if there is a problem with my cognitive health, or to serve as a baseline in subsequent years so I can compare back to see if my memory has declined. So there's the technology and breakthrough, the digital screening techniques, the biomarkers are very, very important. So whereas we've had to have diagnosis based on symptoms for years and years, we now next year hopefully will have a blood test, a very simple blood test that can determine whether or not you either have amyloid elevated on your brain and therefore will soon, if not already, have Alzheimer's, or it can even be determined years before the symptoms begin that you are most likely to develop Alzheimer's. So this is tremendously hopeful.
That's amazing. I mean, you don't often hear in this space, or really any space, if you take any sort of disease specific space or patient advocacy organization space, I think it takes a long time, right, to get to where you are. And I think to have that hope and to see the progress and the action right? To actually visibly see it happening is exciting. And I think it is something that really leads to hope. So we're so appreciative that you brought that up, because I think it's something we don't necessarily think of immediately, right? If you're living in the day to day,
Absolutely.
it's really hard to see it, right?
Absolutely.
Yeah.
I also, my wife died in August, 12 years with the disease, had a wonderful journey. And we were so enriched by knowing the people in this community who really are dedicated to supporting people with the disease and to find a cure. I'm very glad she lived to see the day when there are approved treatments and all these breakthroughs are happening. It was richly rewarding to her. And I think it gave her the sense that her son, who is, but also more, even more so her beautiful little granddaughter, will probably not know the difficulty of this disease because there's real belief and opportunity for us to prevent that.
Oh my gosh. Well, thank you for sharing your experience and your story. And thank you for sharing Jerry with us too. I mean, I think
Yes.
just to hear about, what I think she was able to do and what you have been able to do in terms of raising your voices for the future generations and even for yourselves, I think is really amazing. And we so appreciate that. Was there anything I didn't ask that you wanted me to ask you?
Well, one thing, and we may be over time, but one of the things we're trying to, or we're struggling with somewhat is that it's not a federal agency, but it is an independent medical group called the United States Preventative Services Task Force, USPSTF. I couldn't even pronounce it for a year.
It's another tricky acronym.
So they kind of write the Bible for general practitioners, family physicians. They when mammograms became more accessible, they were not at the general physician level. Articles in magazines women read and would go in and start requesting mammograms. This was very important. And as the technology became more affordable and more user-friendly, physicians realized that they could manage it. So when the USPSTF wrote a new recommendation that general physicians uh, engaged with mammographies for their patients, it changed the field. We need that same thing to happen with early detection, with annual cognitive screening, which is already included in the annual wellness visit. We need this organization to say, yes, we've reached the time. We have treatment, we have diagnosis, we have screening tools, and we have a guide program for care, that now is the time. And if that happened, it would really much more quickly change the physician office and their ability to screen and their knowledge they have. So that's one of the final projects that I wanted to tell you about this morning.
Okay, wonderful. Yeah, and for our audience, if something like that were to get an A or a B rating from the USPSTF, that means it gets covered. And it means that it's taken up as best practice and guidelines. And so that's really important and something we'll definitely be watching and looking to. Sometimes, it can be a little bit of a black box, but I do think that having, the voices raised here is going to be really important in making sure that that can get across the finish line. I certainly think that having those clinician partners who are advocating for it alongside the patients is really critical.
Wonderful. Thank you so much, Katie, for letting me talk this morning and for getting to know you. And thank you for all the work that you're doing in women's health.
Well, thank you, Jim. Thank you for all the work that you're doing, and we'll definitely be continuing to stay in touch.
Wonderful.